This is my portion of a presentation that was given at the Association of Maternal Child Health Programs 2021 virtual conference. I strongly recommend that you look up into their work as well as the work of Lauren Caton and Jessica Cohen. This meeting was originally planned to take place in New Orleans, Louisiana, on land that has been traditionally stewarded by the Chitimacha people. They are a matrilineal tribe in the Atchafalaya Basin. They're the only tribe in Louisiana still occupying their aboriginal homeland. The Chitimacha language is an isolate, which means it's not related to any other language. The last fluent speakers recorded over 200 hours of conversation in order to preserve the language before they died in 1932 and 1940. The tribe has developed Rosetta Stone software to share their language with interested tribal members all over the world. Please join me in paying respects to elders past, present, and emerging. For more information, you can go to www.chitimacha.gov. So now we'll dig right into the presentation. So what is harm reduction? An official definition of harm reduction is that it is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use, as well as being a movement for social justice built on a belief in and respect for the rights of people who use drugs. Another way to think about harm reduction is not so much reducing harms associated with drugs and substance use, but reducing harms with the war on people who use drugs. Because the drugs themselves don't really cause many of the harms. It's the war on drugs that is truthfully harmful. So, okay, that's all very well and good. Big picture, big ideas of harm reduction, but what does that look like in action? You can access this harm reduction flowchart on our website at perinatalharmreduction.org. And basically, harm reduction is any positive change, which is a phrase that was coined by Dan Bigg of the Chicago Recovery Alliance. Harm reduction is working for our clients instead of at them. It's about creating goals based on what the client identifies as their primary goal, rather than what we as providers think they need to be working on or what the institutional policy says that we should focus on. Harm reduction is integrating people with lived experience into leadership positions rather than just tokenizing them as peers. It is also, one very important aspect of it is continuing medical coverage after the postpartum period in the context of pregnancy. So often we find that people who are pregnant are valued only as a vessel for the fetus or the baby that they're carrying. So what this ends up looking like is perhaps the client comes to you and they're using substances, but before they feel ready to work on substance use, they want to work on something else, maybe something that's going to enable them to work on their substance use, such as obtaining housing or employment, maybe something that seems and feels more achievable to them in that moment. It can be really difficult to make a big, huge change in your life, and making small little steps can really build self-efficacy and confidence in order to tackle those bigger challenges. Harm reduction was invented by people who use drugs. We find that a lot of organizations are taking up harm reduction, but it's really, really important to remember that this was a grassroots, community-driven movement before it became the catchphrase that it is today. People who use drugs implemented and designed and fought for every single intervention that we all now accept as best practices, such as needle exchange and syringe access, drug purity testing, methadone and buprenorphine and other opioid agonist treatments, naloxone distribution for prevention of overdose. All of these things were things that people who use drugs started doing before they were legal or allowed or accepted, or before we had data proving that they were good, because we as a community know what we need, and we know that we are the best people to provide those services for ourselves and our communities. So now we'll get into the history a little bit in the United States anyway. Opioids at one time were very useful for controlling women. All those pesky pesky women with their imaginary pain caused by things like polycystic ovary syndrome, fibroids, and endometriosis, rather than actually researching and finding out what was going on with these patients. It was much easier to just throw a bunch of opioids at them. So opioids became really commonly used for all kinds of issues that women had, and they were also used for all kinds of issues that children had. In fact, you used to be able to order some heroin and 2 syringes from the Sears Roebuck catalog. So it was just a normal part of our lives in the early 1800s. Towards the early 19th century, we started recognizing problematic alcohol use as long as you were a middle or upper class white man. And we started trying to respond more humanely rather than punitively in those kinds of situations. The war on drugs really came to full force in the 70s, in 1971, when Richard Nixon declared the war on drugs. John Ehrlichman was one of Nixon's top advisors. And in 1994, just shortly before his death, and after serving decades in prison for various reasons, he gave this interview and said this quote: "You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and the blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did." So it's really apparent to anybody that looks at this history what was going on and what were the motivations behind it. And it's just really gratifying to finally have enough distance that the people involved are admitting that that's exactly what they were doing. So this isn't an opinion, or this isn't a controversial statement. This is a fact that the war on drugs was conceived and implemented in order to mess with communities the government found undesirable. Even at this time, we had tons of evidence-based reports and research showing that the approach that we were taking towards managing problematic substance use was wrong. The National Survey on Drug Use and Health is still going on. They publish it periodically. It's excellent data, and it shows that what we are doing not only is not working, but in some cases is making the problem worse. Around the 80s, with the AIDS epidemic, was when people really started realizing the power of community organizing. We had ACT UP in New York, providing needle exchange and meal services and healthcare for people who were suffering from HIV and AIDS because nobody else was doing it. And that's a pattern that you'll find. People who use drugs have been stepping up and providing the services that we need for decades, because if we're not going to do it, nobody else will. And that's been proven to us time and time again. Around the 90s was when things really started picking up, at least on the coast. The first acknowledged syringe access program started in Tacoma, Washington in 1980s by Dave Purchase, who you see there on the left. We also have tons of other organizations in the Homeless Youth Alliance in San Francisco. We have Vocal New York, Lower East Side Harm Reduction Coalition. And this photo here in the corner is the People's Harm Reduction Alliance, which is the syringe service program that I have worked for. In the early 2000s and right up until about 2010, 2012, we saw massive funding cuts to syringe access services and nonprofits in general, as well as just a real boom in rural programs. So we had Haley Cole starting Shot in the Dark in Phoenix. We have Mona Bennett with the Atlanta Harm Reduction Coalition, and Dan Big with Chicago Recovery Alliance. Dan Big and Chicago Recovery Alliance are responsible for widespread naloxone distribution. And he is the reason why you know that naloxone is the overdose reversal drug. So what are we looking at now? What's the situation now? What we see right now is just a lot of people adopting harm reduction for the first time and kind of taking it over. So that's where we get this idea of the healthcare provider with wings, like, oh, I'm such an angel, I'm doing this work, and really not giving credit and power to the people that have been doing this work for decades. We also see lots of normalization of harm reduction for people who use cannabis, particularly white middle class people who use cannabis. Um, and everything that people who use drugs have been working on and pushing for is kind of pushed aside to the margins. So some of those campaigns are top right, we have Louise Vincent and Just Tilly and their hashtag Reframe the Blame campaign. And this is a response to prosecutors going after the partners, friends, and loved ones of people who die of overdose, um, prosecuting them for homicides based on drug delivery, when really it was just people trying to survive or using drugs together. And um, and so there's a whole movement that they've started where people who use drugs can sign on and say, if I have an overdose and if I die, please don't arrest my partner, my husband, my children for supplying me with those drugs. We also have a push for safe supply, not left to die. This is something that's really popular in other parts of the world, which is drug testing. Because when we have a supply that is so unreliable and so unregulated, that's why we end up with all the fentanyl poisonings that we're seeing these days. So if we had an anonymous and safe and reliable place for people to take small amounts of their substance, have it tested, then they could know exactly what they're putting into their bodies, and people could be a lot safer. Bottom left over here, we have safer consumption spaces. Another thing that has been widely effective in Canada and Europe and other parts of the world. These are healthcare clinics where people can come in and bring their own substances. They can then get clean and sterile supplies and use their substances under the supervision of a healthcare provider. And in this way, we can not only prevent overdose deaths, but we can also have a linkage to services, because one of the hardest things about providing services for people who use drugs is that we have done such a terrible job of it historically that we've scared people off. People will not come to the doctor or the hospital because they're afraid of abuse that they may have experienced before or somebody else may have experienced. I personally have pleaded with a friend who had a broken leg, which you could see the bone sticking through the skin. And I said, I'll go to the hospital with you. I'll stay with you. I will help you through this. But he would not go to the hospital because of just a history of abuse. People are getting abscesses lanced with no pain medication. People are being sent home after major accidents with just Tylenol because of the widespread and accepted abuse of this population by healthcare providers in our system. So having a healthcare clinic where people can come and be treated like a human being, even if they are someone who uses drugs, can be that essential linkage to care, so that if and when they are ready to seek treatment for their substance use or health care for some other reason, or even social services, they already have a point of contact that they trust. So this can be just vital in building those networks of care for this population. And then we have the foster system and the way that interacts with the drug war. There are many, many organizations beside my own that are working on this issue. We have Movement for Family Power, who's based in New York. There are national advocates for pregnant women, Elephant Circle, the Birthrights Bar Association. There are many, many legal advocacy organizations that are working to correct some of these very similar abuses of this population that happen in our legal and child welfare systems. Children are frequently taken away from their parents for nothing other than substance use. Even though every professional organization recognizes that substance use in itself is not child neglect or abuse. We're seeing people I spoke to one lawyer in LA County who said that 90% of the cases on her desk right now were for cannabis use in the absence of any other allegation of child abuse or neglect. And this is something that must stop. Our country has a long, long history of stealing the children from people of color and indigenous communities. And that is part of the United Nations definition of genocide. And it is unacceptable, and we have to stop looking away from it. So it shouldn't surprise anybody to learn that the war on drugs is a war on people of color. People of color, Black people and white people use drugs at similar rates, but Black people are imprisoned almost 6 times at the rate of white people, even though they use at similar rates. In October 2016, there have been almost 2,000 exonerations of wrongfully accused people, and 47% of those were African Americans, which is not proportionate to their population. African American defendants are 22% more likely to have convictions involving police misconduct that eventually result in exoneration. And we know from recent killings, murders of George Floyd and Breonna Taylor, that drugs are often brought into the story after the fact as a justification for killing people of color. And this has to stop. So this is a graph from the Hamilton Project. Over here in the green graph, we see that Black and white people use drugs at similar rates, white people a little bit more often than Black people, and they sell drugs at just about the same rates. However, the rates of drug-related arrest are about 3 times as high for Black people as they are for white people. Drug-related incarceration at the state level is about 6 or 7 times as high for Black people as for white people, and drug-related incarceration at the federal level is even more disproportionate. So despite the evidence that we know that we're using drugs at similar rates, the reaction to our drug use is not the same. And there's a reason for that, and it is racism, both individual and systemic. The war on drugs is also a war on women and other people who can become pregnant and their children and families. Most incarcerated women are in prisons and jails because they were accused or convicted of a nonviolent drug offense. 3 to 10% of women admitted to prisons and jails are pregnant at their time of admission. And this is probably a vast underestimate because most prisons and jails do not ask or test for pregnancy. I suspect that's because they don't want to provide health care for pregnant and parenting people. More than 60% of incarcerated women have children under the age of 18. And this is significant because we know that when fathers are incarcerated, the children are typically cared for by their mother. But when women are incarcerated, the children typically go to a relative or the foster system. So when we're incarcerating, as we are increasing the rates at which we incarcerate women, which it's gone up at twice the rate of men, or 9 times in 40 years, we know that this is not only breaking up that person's life, it's breaking up their family, and it's breaking up communities, and it's hurting children. So the last thing I want to talk about is how stigma is what is killing us. It's not the drugs. People are able to use drugs in a safe way if they have adequate supports, adequate information, and adequate systems. What we see instead is punishment and shame, which results in people hiding their substance use, not only from their healthcare providers, but from their family and friends. Somebody you know is hiding who they are from you because they think that if you knew the real them, you wouldn't love them anymore. And they're probably right. People who use drugs are rising up. There are multiple drug user unions around the country working to fight for the rights of people who use drugs and stop these abuses. Organizing is the best thing that we can do. When we are organized, we can't be beat. Organizing and working on harm reduction gives people a sense of pride and self-efficacy, and it is working. So many of the things that people who use drugs have been fighting for decades are finally coming to fruition now, and we have our elders to thank for that. So what does harm reduction look like in the perinatal period? Firstly, it's really important to remember that people who use drugs, just like everybody, is a whole person and they may have multiple things going on. So everybody who uses drugs needs the typical prenatal care that you would offer to any client. So we need primary care, dental, vision, prenatal care, postpartum care, longer than 6 weeks, please. We need nutrition, SNAP, housing, and also community services, social services, and support. Items that are specific to people who use drugs are gender-specific treatment options. So oftentimes when I bring up this topic, people are like, oh, well, they need to go to treatment, send them to treatment. There is no treatment. If you are a single mother who has, maybe you're pregnant and you have a young toddler, how are you supposed to go to treatment? There are not gender-specific treatment beds available. There are not inpatient programs that you can bring your children to. There is not childcare available at outpatient programs. There are things that women and other people who can become pregnant need that are different from what cisgendered men need. And all of our programs have historically been designed for cisgendered men. So that's something that we could start working on right away. There's a couple dozen programs specifically for pregnant and early parenting women and other people with uteruses in the entire country. We need to stop stigmatizing medication. Opioid agonist treatments such as methadone and buprenorphine are and have been the gold standard of care for this population and really for anybody who uses drugs. We need trauma-informed care. And a lot of folks think that this means that the clinician needs to know what trauma people have experienced, but that in itself is a form of re-traumatization. Trauma-informed care means that we provide services in a way that anybody with any kind of trauma would be comfortable accessing your program. We need safe supply and prescriptions for opioid agonist treatments. It's not going to be possible to prevent overdoses and soft tissue infections and all these kinds of things as long as we have such a contaminated and poisoned drug supply. We need safe equipment and alternatives. So part of this is clean and sterile equipment such as syringes, but part of this is also providing snorting kits and pipes and other methods of administration, the kinds of equipment that people need, because a lot of times people don't necessarily want to inject, but if you can get needles for free and it costs $10 to $20 to buy a pipe and you don't have enough money for food this month, what are you going to choose? So in some ways, we're actually pushing people towards a more dangerous and more risky method of administration when providing full service harm reduction would actually prevent a lot of that from happening. We also need safer consumption spaces, both to provide people with a safe and warm and clean place to inject, and also as a linkage to service, like I was talking about earlier. So even if all of this ethical and moral and outcomes-based arguments isn't doing it for you, or perhaps not doing it for your managers or your higher-ups in your organization, this harm reduction also makes sense from a financial perspective. It's estimated that one new HIV infection costs taxpayers $400,000 a year. One clean syringe costs 13 cents. It's not that hard of a decision. I want to talk a little bit more about the gold standard, which is opioid agonist treatment. Like I said before, this is not only a gold standard for people, for pregnant people, but also for anybody who is having problematic substance use. A couple terms that you may see are opioid agonist therapy, OAT, or MOUD, medications for opioid use disorder. These are the emerging terms that we're using instead of MAT, medication assisted treatment, or MRT, medication replacement therapy. And the reason for that is because these terms are more precise and accurate and less stigmatizing. So methadone and buprenorphine in this country and heroin in Canada and some other countries in Europe and Northern Europe are the ideal treatments for people who have opioid use disorder. And the reason that these are so effective is because it's not the drugs, it's the context. If you are able to have a safe supply of your substance of choice that keeps you from going into withdrawal, and you don't have to spend your entire day hustling or figuring out how you're going to get money to pay to avoid being sick while paying your rent or your childcare or your groceries, that creates a stability that allows people to work on all aspects of their life, and it has really been shown to be the best for all people. In pregnancy, we see the same thing. When you have a stable and safe and consistent supply of opioids, we see better outcomes for both moms and babies. Just a side note, we do see slightly improved outcomes with buprenorphine in pregnancy versus methadone, but it's difficult to say whether that is because of difference in the medication or whether that's because people who are able to access buprenorphine tend to have better social determinants of health. So what should you know about medications? We see that improved stability, decreased risk of infection, and decreased risk of violence, frankly, for women and other people who can become pregnant. We also know that it is safe for human milk. And because of its stabilizing effects, it is preferable to withdrawal, detox, or abstinence as a goal for somebody who becomes pregnant while suffering from an opioid use disorder. It is not pain control. This is medication that keeps people stable. They are not high, and they're going to need additional pain control, especially if they end up having a C-section. The point of any treatment for a potentially fatal condition is to stay alive. A lot of folks think that an assumed goal of methadone or buprenorphine treatment is to eventually get off of it. And that may be true for some clients. However, some people are going to be on these medications for years or potentially their whole life, and that's okay because the medications are working, and that is a success. We also see folks expecting the clients to get on methadone or buprenorphine and then immediately be fixed. But we know that relapse is normal and expected part of most people's recovery. We also know that continued illicit substance use is expected and does not mean that treatment has failed. What we see is drastically reduced illicit substance use, especially over time when people are on these medications. During the ANCHIP presentation, we got a great question from somebody named Rose, I believe it was, and that was, what do you do for, I'm paraphrasing here, for people who are using substances but are able to stop without treatment? And to that, I say, not necessarily anything. We know that about 80 to 90% of people who use substances do not have a problem and end up stopping without any kind of treatment or intervention at all. So when we're talking about treatment here, we're talking specifically about people with a diagnosable substance use disorder, not people who used drugs when they were teenagers and don't anymore, which is the case for most folks. We also know that plenty of responsible adults and parents use substances sometimes without problems, without safety concerns, and while managing their responsibilities and their children. So when we're talking about medication treatment, we're specifically talking about people who were unable to stop using on their own. Great question. So what are the challenges to implementing harm reduction in all of our systems, in all of our programs? We have the evidence. We have had the evidence for 50 odd years. We know what we should be doing. Every professional organization from both the medical side and the law enforcement side are all recommending the same thing. The challenges are ideological and political. So we see NIMBYism, not in my backyard. People say, oh, well, that's all very fine, but I don't want those services around me, which ignores the fact that the services are put in places where the people who need the services are. So when you're saying you don't want those services in your neighborhood, you're saying that you don't care about your neighbors. We see healthcare professionals who don't want to touch people who use drugs, who don't want them in their clinics, who don't want them to be a part of their practice. And they make this very clear by perpetrating some of those abuses that we were talking about earlier. In the meantime, we see graphs like this one at the bottom, where we have had just exponential increase in overdose deaths in the last several years. And these are people. I think that gets lost so often because we're trained from birth, really, in this country to think of people who use drugs as something other, as not like us. But these are our friends and our neighbors and our family members and our lovers. These are people, and they're dying preventable deaths because of our inaction. We're also seeing children torn from their mothers in the middle of the night and taken away from them just simply because their parents tested positive for a substance. This is what's happening. It is life and death. It is literally life and death and ripping families apart. And we need to start giving a shit. Thank you.